He is presenting an air saver of cornea, efficacy of pneumodescematope in managing descemet membrane detachment.
Good evening, everyone. My topic is efficacy of pneumodescematope in managing the descemet membrane detachment. Introduction. Descemet membrane detachment is a well-organized and potential vision-threatening complication of cataract surgery. It occurs when fluid enters the corneal stroma through a break in descemet membrane or an area of separation between the descemet membrane and the corneal stroma. Prolonged corneal edema leads to fibrosis, shrinkage, wrinkling of the detached descemet membrane, which may prevent the reattachment and necessitate the endothelial transplantation. My objective is to evaluate the visual prognosis in case of descemet membrane detachment post-pneumodescematope following cataract surgery. It is an interventional prospective study. I take a patient presented with a non-resolving corneal edema after cataract surgeries, and it includes inclusion criteria is a patient with descemet membrane detachment after cataract surgery, partial or complete descemet membrane detachment involving visual axis, and descemet membrane detachment with overlying corneal stromal edema. My exclusion criteria is detachment involving less than 20% of the corneal, only periphery involvement, descemet membrane detachment due to other surgeries like keratoplasty, iridectomy, trabeculectomy, and vitrectomy, and descemetopexy performed along with the primary cataract surgery. I studied a 12 patient presented with a non-resolving corneal edema following cataract surgeries. On ophthalmic evaluation using slit lamp biomicroscopy showed various types of descemet membrane detachment, superior, subtotal, and inferior. This has been confirmed in anterior segment optical segment tomography. The surgical technique used under topical anesthesia, 26 gauge cannula mounted with 5 ml disposable syringe and with syringe filled with 100% air. A continuous single bubble of air was aimed into the anterior chamber, and inferior peripheral iridectomy is done to prevent the pupillary block. A side port hydration made or sutured with a 10-0 nylon. Here showing a pre-op picture of a patient having a descemet membrane detachment, and the AIOC shows a descemet membrane detachment. We did a pneumodescematope for the patient, and the result, after the procedure, the patient has been followed for 1 month. In my case, 10 out of 12 patients had a good descemet membrane attachment, and on follow-up corneal edema resolved with a good visual prognosis. These are my patients' post-op visions, post-op cases having a good corneal, clear cornea, and the AIOC shows a resolving corneal edema. 2 patients has been planned for optical penetrating keratoplasty. Outcome, all patients had a pre-op visual acuity in a range of hand movements to 360. In my final outcome, 25% of the patient had improved a visual acuity of more than 624, and 33.3% had a visual acuity of 620 to 624, and 25% patient had a visual acuity improvement from 360 to 660. A conclusion, descemet membrane detachment is a rare but vision-threatening complication following cataract surgery. Pneumodescematope is a safe and effective procedure in managing the descemet detachment. Descemet membrane detachment can spontaneously reattach with medical treatment alone, but while large detachment or slow resolutions are treated with descemetopexy with air. An early intervention with pneumodescematope was associated with a good final anatomical and visual outcome. Thank you.
Did you use other types of gases, like, because nowadays just simply large detachment that will not be taken care by air only? So what is your comment about that?
We used only air. I have not used any other C3, F8. I have not. We have studied along only.
Why did you use other gases? Normally, descemetopexy means these long-standing gases.
With the air, it has good outcome according to.
Air will stay for 24 to 48 hours only. After that, there will be no effect.
So what do you think the 2 patients failed? No? You said there are two patients failed, and you saw them after 1 month of pneumodescematope?
Yeah.
When did you recognize that they are failed?
On my follow-up, they have not having non-resolving corneal edema. They have presented with the non-resolving corneal edema that the DM has not been attached. So we have planned for an optical keratoplasty.
Thank you.
What was the ideal time when you take up a patient presented with DMD? So how many weeks did you wait? Did you take it immediately, or what was the maximum period of waiting?
After post cataract surgery, we evaluated in a slit lamp. If there is a non-resolving corneal edema, and in slit lamp, if there is an DM detachment, and we can confirm with AIOC, we will take immediately in the next day or no.
Presentation from 1 week to 3 weeks or 3 weeks to more? Did you go for DMD with desmetopexy or more than 3 weeks? What was your?
We present within 1 week also we have taken our presentation. After 3 weeks also we have taken.
Is the ideal thing, but what if the patient has presented after 3 weeks? How did you treat the patient?
We tried Pneumodescematope for that patient also.
So the results were good with that?
No.
So what do?
Early intervention has a good visual outcome.
And in one of your slides, you have pointed that you did a side port hydration.
Yeah.
May I know why did you do side port hydration? To release the airfill of 100%, or was there any other reason for that?
To have a good air tamponade, I haven't done.
Air tamponade you wanted 80% or you wanted 100%?
100%.
So then why did you do side port hydration? No, I mean, I just wanted to know because if there is any logic so that I can also use it.
So, can I call upon the next speaker, Dr. Kiruba?